Hey guys, in this lesson we're going to have a very quick conversation about Ctas, how we use it on everyday calls, and finally some unique situations in where the standard triage rules don't really apply. First up is Ctas. Ctas stands for Canadian Triage and Acuity Scale, and it's a tool used in virtually all Canadian EDs to help nurses and physicians figure out how quickly a patient needs to be seen. Now, before we get too far into this, Ctas is mostly designed around the emergency department setting, but there are obviously a lot of implications in the pre-hospital environment as well. Being able to assess a patient and then accurately tell the ED how sick they are using the same terminology would be huge in getting our patients the appropriate treatment quicker, as well as helping us get freed up from these offload delays. The thing is, because Ctas is focused on the hospital setting, some of the terms and recommendations may not be applicable to the typical pre-hospital situation, and the sheer volume of resources here can be a little bit overwhelming. They're currently working on a pre-hospital Ctas scale, so we can use that to translate this to the ambulance. So Ctas works by assessing the patient based on a quick look at the patient, an evaluation of the patient's chief complaint, and then by applying the first order and second order modifiers used in Ctas. The quick look is just as it sounds. It's our initial impression. Are you sick or not sick? Ctas evaluates a patient's chief complaint based on a list provided by Ctas, Canadian Emergency Department Information System, which lists out common chief complaints based on different categories. There's 18 categories in total, like cardio, respiratory, neuro, etc. First order modifiers are basically our primary assessment, A, B, C, D, and E, with the second order ones being pain, bleeding disorder, and mechanism of injury. Think of things like risk factors or confounders. If you have any of these, you may be sicker than you're initially presenting. The idea here is that you'll take this information and apply a score to the patient, 1 to 5, with 1s requiring an immediate physician assessment and 5s being able to wait a little bit longer, recommended to be seen within 2 hours. Ctas is the type of thing that you should have a resource in front of you to apply correctly, especially as you start using this tool. Your first few times assigning a Ctas level, just compare the complaint and the initial assessment to whatever chart or reference you have to make sure you're doing it right. It's very intuitive, and after a while you'll be applying scores much more quickly and competently. So let's do an example. 45-year-old male was involved in a rollover MVC. He has an obvious head injury, firm and swollen abdomen, altered LOC, poor respiratory rate and depth, and is hypotensive. Using Ctas, on our quick look, the patient is obviously sick, so we could assign a level 1 right away. Besides that, we would also say this patient has a chief complaint of major blunt force trauma and is presenting with altered LOC, respiratory failure, and hypotension. So he should definitely be a Ctas level 1 and be seen in resus. Let's do one more. 25-year-old male who smoked too much marijuana. He's nauseated, vital signs are stable, possibly a little dehydrated. Applying Ctas to this patient, he looks relatively stable, has a complaint of nausea vomiting, and his first and second order modifiers are all fine. We would likely assign him a level 4 or 5, and he can go to the waiting room for a bit. So this is why Ctas is so important to EMS. If we called the ED with both of these patients and only gave them the Ctas number and no other vitals, these patients would end up in the exact right area of the ED and still receive appropriate care. Ctas provides us with a way of clearly communicating how sick a patient is by a standard metric that everyone can use and follow. Last point on Ctas, like I said, it's a real big document with 18 categories of chief complaints, and each of those having multiple sub-chief complaints, and then each of those having parameters to assign a patient score. And this is just for adults. Pediatric patients have their own type of Ctas. So that being said, as you begin to use Ctas and become familiar with treating patients, you'll soon be able to recognize what constitutes a level 1 to 2 and a level 4 to 5 pretty quickly, and you'll only need the reference for fine-tuning your score.